We will now turn to the presidential lectures. And the first is, we honor two senior members of the history of our society, one of them alive and one of them has passed. We will first start with the Stanley Fahn lecture, and this is a clinical lecture, and it is given to a seminal member of our society who has contributed in a fundamental way to the understanding of one or many of our diseases, and also has served, very importantly, as a role model for our younger members. And without any real controversy whatsoever, this year the awards committee, based in the Congress Scientific Program Committee, selected Marie Vidailhet from Paris. And I have known Marie for years, really decades, because we were very early in Paris at the same time. At any rate, Marie has contributed enormously to the understanding of dystonia, and also has served as a real role model. She is very active with the newly formed European Academy of Neurology. She is the director of the scientific program, I believe, but very active in that organization as well as the Movement Disorder Society. So it is a great pleasure. And you will notice her kind of fascination with the subtleties of the English language with this clever title of Dystonia or Dystonias, Hybrid of Wonder and Mystery. It's a lovely title. Marie, would you come and lecture to us?
Good morning, everybody. Thank you for being here and getting up so early to be here this morning. It's a great honor and privilege to have been invited to give the lecture, the Stanley Fahn lecture. Stanley Fahn is inspiring to us neurologists. He's a great clinician, a fantastic clinician, with an exceptional ability to observe the patient and see through them and see what other people may not see. From that power of observation, he could pierce the mysteries of mechanism of dystonia. Today, we will walk on his footstep, and I will take you with me to show you what my patients taught me. And I will have to do a very complex motor task, which is to master that kind of thing. So, what can we learn from our patients? We will take a fresh look at the clinical diversity of dystonia and see, as Professor Stanley Fahn did, what have been overlooked. From that on, we will connect clinical observation and scientific concepts. And then we will transfer knowledge into therapeutic perspectives. Dystonia, or dystonias, hybrid of wonder and mystery. Dystonias stop the travelers, that's us, on the road and pose them a riddle. The riddle is, can we decipher dystonia? We will take a fresh look at the clinical diversity of dystonia, and I will select 3 examples of dystonia: task-specific dystonia, cervical dystonia, and generalized dystonia. Cervical dystonia. Let the past shed light on the present. In the 19th century, in the Salpêtrière, at the time of Charcot, Duchesne de Boulogne described in details the cervical dystonia, torticollis at that time. And very soon after, Destarac described the geste antagonist. I will show you what this patient told me. If you look at him at the moment, he has a very severe cervical dystonia with jerks, abnormal movements, abnormal posture, and it's getting worse when he walks, and it's getting worse when he stands. So you see this abnormal tone control, the jerks, the overflow, and he will have the geste antagonist. the geste antagonist, or the sensory trick. There are two words, a French one, geste antagonist, and an English one, sensory trick. They look alike, but to me, they're not quite the same. Why is that? Geste antagonist is a movement with a gentle positioning of the head to a close to normal position. Having said that, you have the touch and you have the movement. So you have the integrated sensory motor correction. Sensory trick is a trick to treat dystonia. So it implies that you go mainly through proprioception. And we will see that going on along this presentation. I freeze intentionally this video on the geste antagonist with two snapshots. As I told you before, the geste antagonist in this particular patient integrated the sensory trick and also this movement and gentle push on the head that makes a position on a straight position or close to normal. We will see another patient and we illustrate something else. See now what may have been overlooked. This patient is with Jean-Pierre Bleton, who is also very inspiring and very creative in physiotherapy. You see that with his finger, he asks the lady to follow the finger, and he attracts her gaze and head towards his finger. So in the very first minute, she couldn't turn her head, and now she can do it. So it's a head and eyes coordination. And you see that she now can turn her head on her own. Only one head, despite a hybrid. So with the geste antagonist, she can also turn her head. So that's the sensory motor integration. So from this video, what we may have overlooked is a combined movement of head and neck. So we may hypothesize that there is a head and eye neural integrator with either dysfunction or abnormalities into the brainstem. What can we tell about this brainstem function alteration? Well, there may be a dialogue between the mesencephalic structures and the other, which are connected. Proprioceptive afferences, cerebellum, basal ganglia, and cortex. So we will go deep into it. We will focus on brainstem, the nuts and bolts, you know, this kind of thing that you just put that together. And we will connect this observation with a scientific concept. Well, from this paper, who collected data from the 80s and 70s, data which were recording of neurons at the time when they were operated in the brainstem for the treatment of cervical dystonia. And these neurons, this single neuron activity during stereotactic surgery, were identified, and some of them were neck neurons that responded to neck movement with amper integration of head movement. So in other words, the interstitial nucleus of Carroll may be this mesencephalic head integrator. So we are really focused onto brainstem. And then the dialogue, the abnormal dialogue between the mesencephalic head integrator and its inputs, the proprioceptive afferences. There are massive proprioceptive afferences from the neck and from the movement and also from this huge sensory information that comes from the neck. And this information is computed, so to speak, by the cerebellum and of course by the ganglia. So to wrap that up, there is an abnormal cerebellar processing of the neck proprioceptive information, and it drives the function of this mesencephalic head integrator. So that's the nuts and bolts. With that on, it fits the vicious circle and reinforce the dystonic phenomenon. So now we go from the scientific to the mechanism, if we can. First, I want to tell you something because I want to attract your attention on the fact that the cerebello-thalamo-cortical communication is preserved, but is locked and is abnormal in an abnormal processing of proprioceptive input. So what are the players? The player is the corticospinal system, the motor control, very simple. And then the loops. And in the loops, you go from the sensory efferentings to the cerebellum, through the basal ganglia, through dysynaptic connection, the complex machinery of basal ganglia, and back to the cortex. And if you pay attention to it, you can find out how to treat these patients. And you know all, because you've done that every day in your daily clinic, that we can treat this patient with botulinum toxin because you decrease the strength of the muscle and you also decrease the sensory afferences, so to speak. And of course, we can treat them with deep brain stimulation. There were yesterday brilliant lectures on that topic. We can also imagine new treatment because we have the concept in head. So the new treatment, you saw an illustration, is physiotherapy. And these patients have an impaired force perception. They don't know exactly where their head is. And we have to retrain them in this proprioceptive sense of position of the head. We can imagine non-invasive stimulation. At the moment, a lot of work is done in this subject. And this non-invasive stimulation can be done on the cerebellum. Or if it is invasive stimulation, a few papers published anterior lobe invasive stimulation of the cerebellum. It's a bit daring. And, of course, we can go through the loop, and we can imagine, now it's not completely done, a modulation of the rhythmic activity of this anterolaminar projection of the striatal interneurons. And, of course, all good things, which are the pharmacologic modulation by the interneurons, by the cholinergic treatments of these cholinergic interneurons. Sorry for the mistake. So, now we have seen a few things about cervical dystonia. We go back on the road, and now the traveler, all of us, is stopped again, and we have a second freedom. We have to deal with the rebel movement, the rebel hand, and we talk about task-specific dystonia. There are many examples of task-specific dystonia, writer's cramp, musicians, and so on. Today, we will focus on upper limb dystonia and take the example of writer's cramp. Let us take a fresh look at this clinical diversity of writer's cramp and try to see what we may have overlooked on writer's cramp. What about the hand? Hand is really something which is unique. Why is that? Because the hand is one of the most distinctive traits of humanity. If you read a comparison that has been done between the hand of the man and the hand of the closest primate, you see that they are morphologically different, and we have a longer thumb. They are also functionally different, although these animals are very skilled. There is in man an increasing degree of fine motor abilities, dexterity, and specialized learning, but it implies that we will have a fine-tuning of motor substance. It's a blessing to have this dexterity and this ability. And we can master very complex skill, but it may be also a curse, because it's a very highly demanding task. It's very skilled, often it's overlearned, and of course we do it many times, and it's repetitive. And then this blessing becomes a curse. Let's see a man who taught me a lot. This gentleman has been working for long years, and he has been writing several days, and several a week, and several hours a day. And he has a long-standing history of writing cramp. You saw in the videos that he had not only writer's cramp, but it's propagated to the keyboards and then to the mouse. It's because he had a lot of repetitive movement, and the load on his hand, on his brain, was huge. So it was not a load, it was overloaded. He has an intense writing overload, and we'll come back to that. We saw the overflow of the movement and also the contamination of other movements. You see that the pattern of the movement is altered, and you maybe notice that the pressure on the different tools is increased, and he doesn't know exactly if he pressed hard or not. And we work at the moment on this loss of sense of agency. As the disease progresses, things get worse. And you see that it has abnormal movement even at rest. And when it takes something in the hands, the movements get worse. And now you will see that you will hold a book and you cannot read the book because the hand is moving all the time. So the dystonia is present at rest and its abnormal movement gets worse with contact. So we cannot adapt the pressure to object. And then we have an illustration of what is sensory motor integration, abnormal sensory motor integration. So, can we connect these clinical observations and the scientific concept? There is a host of abnormalities in dystonia, and especially in upper limb dystonia. I will not give you the whole list, but there is a lack of inhibition from cortex to spinal cord, with this very nice picture from John Mink, with the defective surround inhibition, and the movement is not filtered very well, and there is no surround inhibition, and Mark Hallett worked beautifully on that. There is also a loss of spatial selectivity, and that's rather old work, but it was done by Sabine Meunier in our team, and he showed that there was a loss of the cortical map here, of the position of the finger on the primary sensory cortex. And also there were a loss of the motor maps that were completely mixed up at the subcortical level in the basal ganglia. And they had that bilaterally, which means that there was also an endophenotype on the side which was not symptomatic, not affected by the symptom of dystonia, but affected by the disease dystonia. So, can we connect this clinical observation and all these thoughts together and try to transfer that into scientific concept? We saw that there was an altered movement pattern. And the two red spots, and I want to attract you on that red spot, is the intense writing overload and the distortion of motor learning. What can we say of that? First, the intense writing overload is an environmental factor, very difficult to pronounce. It's a repetitive activation of a very skilled task. And sometimes it's embedded in biomechanical features, that is, peripheral features. And the second is a distortion of motor learning. Motor learning is something which is impaired in dystonia, and it implies, and it's underpinned by abnormal synaptic plasticity, and there is a malfunctioning sense processing, and it's an abnormal inhibition. Altogether, if you take the environmental factors and the abnormal synaptic plasticity, it doesn't give you a big smile. It creates abnormal motor engrams, and that's dystonia. Just to mention, the alteration of LTP plasticity is one of the signatures of dystonia, and it was coined by Quarteron, maladaptive plasticity. So we conduct this clinical observation, and all together we bring into that the last key player, the cerebellum. And the cerebellum has many functions. And I will just attract your attention on two. In this particular case, in writer's cramp, in upper limb dystonia, there is a distortion of the internal model of the movement. And we saw already that there is also a defective cerebellar control of cortical plasticity. So if you put that together, these processes get wild. And these processes, which is used to plan, execute, and monitor movement, is deeply involved and deeply impaired in dystonia. Now we go back to the networks. It's a very oversimplified cartoon. And we will try to find what kind of therapeutic we can bring into that. Well, we try the botulinum toxin, but it's not easy to master in writer's cramp. We can try non-invasive stimulation to modulate the cortical activity. We can even try to modulate the cerebellum, but it doesn't work that well. And there's a new technique with ultrasound that may be proposed, and it was also proposed to have thalamotomy in some musician dystonia. Altogether, writer's cramp, upper limb dystonia is not easy to treat. And non-invasive stimulation was tried, but with non-very convincing results. Some were good and some were more disturbing, not very efficient for the patient. So we are far from the treatment. So we take our way again. We are on the road again, And now the riddle will be generalized isolated dystonia. I give you a very bizarre sentence, which is summing up remembrance of things past. It's taken from Shakespeare, which we twisted. What does it mean? Something happened in the past. It's like the beginning of the earth. We know that it happened. We don't know what happened exactly, and we have no way whatsoever to find out what was happening at that very moment. So that's the same for generalized dystonia. Something happened sometime in the past, and we will try to guess what it was. I will give you only one example, which is on a child, because disease starts in children. This young lady was seen at the Joint Pediatric Clinic in Trousseau with Diane Dumas and Nathalie Dorison. And she was fine until that age, with normal delivery and normal development. And she developed very quickly lower limb movement, which were dystonic foot. And then very soon, she developed generalized dystonia, and this lady couldn't, oops, the video is not working, should do, but, and she had a really bad generalized dystonia. But the mystery of this story is underneath, hidden, the normal motor control was still present. That's the mystery that also wonder, why is that and how is that? And now we can just wake up this normal control. I will try to see what haven't been overlooked in this story, because it was a sample with generalized dystonia. But one thing matters that may be overlooked is age. From the works from Susan Bresman and Laurie Ozelius and many of you, we know that the age of onset in this kind of generalized dystonia related to a mutation in the torsin A, DIT1 dystonia. It's early onset, and the median age is between the age of 9 and 10. And depending on the body distribution, the age is not quite the same. If you start in the legs, the median age is 9. If you start in the arms, the median age is 15. And it can be later when you start only on a focal dystonia. So I will bring together things that may not be related, but maybe they are. And I will show you something which is about the work on the development of basal ganglia, cerebellum, and cortex in children over time. So that's a developmental pattern in normal child, and we will consider only a few structures of the brain. And they don't behave the same. The cerebellum doesn't have the same evolution as the basal ganglia and as the cortex. But the beauty is these two blue and red lines. See the age, 10 and 15. Oh, strange. Same as the one with the onset of dystonia. So if we put that together, it may tell you something. This development, which is normal in children, may be altered in patients with dystonia without us knowing. And that may be the turning point where they are starting to have dystonia before the symptoms appear. So it implies that development is very important in dystonia, and that dystonia is a developmental disorder. So we connect this clinical observation and the scientific data. And we saw that there is a time window that exists in humans, but also in animals. And we take rodents. What is the adolescence of a rat and of a mouse? Well, it's rather early. It's P15 to P35, when motor memory is shaped by the activity, and there are changes in the striatum. In these models, you will have two things, striatal abnormalities and cerebellar abnormalities. Let's see the striatal first. This is during the susceptibility period of this animal, postnatal. They have the long-term synaptic plasticity is different. It's too early, it's premature. The long-term potentiation is premature. And then the long-term depotentiation never appears. So these patients, these animals, get stuck in a place where they have always this potentiation. And they have also structural and functional abnormality, and they have an advanced stage of spine maturation, and they have abnormalities also of the EMPA receptors. So if you take the two together, on one side you have the alteration of the ATP plasticity, and we learned that it was a hallmark of dystonia, and on the other hand side you have the synaptic plasticity alteration. So at that time, things turn very bad, despite the fact that the symptoms haven't appeared. And in cerebellum, it's almost the same story. There's also a time window, and that's more or less the same. It's a P14. And on one side, you have electrical activity, abnormal, erratic cerebellar output, and there is dysfunctional intrinsic pacemaking activity of the Purkinje cell, and therefore aberrantly, and of the deep cerebellar nuclear neurons. We have a low rate, it's shown in the picture, and are also highly erratic. And on the other hand, they have structural abnormality, and again, it's about the synapse. We may even say that dystonia is a synaptopathy. And in this synapse, there is a decrease in the number of spine of the distal synapse, dendrite of the Purkinje cell. So there is a delayed synapse formation. So during this susceptibility period, there are functional and developmental abnormalities. Later on, we are a bit stuck because we don't know if it is compensation or if it is related to the disease per se. And this beautiful work who was presented here on this video, on this picture, shows that there are abnormalities, so to speak, of the thalamocortical tract. Intuitively, we would say that the smaller the root, the worse it is. No, that's the other way around. The bigger the root, the worse it is, because the signal is fueled through a big road, and it's a traffic jam. So, in a protective or compensatory or developmental mechanism, there is a thinning of this thalamocortical tract, and it shapes the fact that the patient has symptomatic or is not symptomatic, and it also shapes the clinical appearance of the dystonia, that is, the phenomenology. So, is it a cause of compensation? We will never know. So can we transfer that into therapeutics? Well, that's not easy, because we have the ropes, we have the rules, we have the treatments, but we cannot be very creative at the moment. So we still have botulinum toxin and deep brain stimulation. We could modulate the sensory afferences that are fed into the cerebellum with physiotherapy, proprioceptive sensor for training. We could try also to change a little bit the tuning by biofeedback, visual training, visual and vibratory feedback. And then we will try again to modulate the different places in the network, but it's far for sample because the disease is more complex than expected. So if we wrapped up that in a very oversimplified manner, I would say that I will propose you a cartoon, which is probably not true, but it's a concept that I had in mind and wanted to share with you at the moment. We saw that dystonia is a developmental disorder, and it's also a network disorder. And at the moment, one of the ideas is that the cerebellum is a key player, and that the cerebellar output disrupts basal ganglia function. So the culprit may be the cerebellum, by the time being. So, how is it? The actor is still the cortex. The integrator, very oversimplified, is the basal ganglia, and the critics that compares the afferent and efferent information may be the cerebellum. And if you feed into the cerebellum bad information, it will just compute them and make them up and get them worse. So, it's a very complex sentence, and I suggest you read it because I may stumble on it. As you see, there is a misprocessing of the sensory feedback. We can even say that dystonia is a sensory disorder. It's combined with an abnormal inhibition within the matter circuit. And it may produce somewhere in the network abnormal synchronization, and abnormal plasticity. And it could be in local nodes or in distant nodes. And eventually, taken that together, we don't know which node will dysfunction the most. It brings dystonia. We almost finished our journey on the footstep of Professor Stanley Fahn. And I ask you again this question. Dystonia or dystonias? You will have the answer by yourself. It's definitely an hybrid of wonder. We wonder a lot of questions and mystery. So at that time being, have we answered these three riddles? And then we try to summarize what we have seen with the diversity and the scientific concept and the therapeutic approach of writer's cramp, cervical dystonia, and generalized dystonia. In cervical dystonia, the key thing is there is an abnormal cerebellar processing of this proprioceptive information, and the nuts and bolts are the dysfunction of this mesencephalic head integrator. So it's something which is really low level. The brainstem matters and the cerebellum matters, and the discussion between the two is important. For writer's cramp, upper limb dystonia, task-specific dystonia, the environmental factor, the overload, is very important. It could be one of the triggering factors, although it's not the cause. And that mixed up with abnormal plasticity, defective cerebellar control, and the abnormal internal model, because it's also all the representation about how I do something and do I do it well, and am I aware of what I'm doing? It's agentivity. And for generalized dystonia, it's really a developmental disorder. I will insist on this vulnerability of this critical time window, and that's a network disorder. And by the time being, my hypothesis that I will share with you, but I'm not sure that I'm right, and I've been inspired by both Gina and others, is that the cerebellar output disrupts the basal ganglia function. Let's have a deep breath. Dystonia or dystonias, hybrid of wonder and mystery. Is there another mystery? Yes, and it's a beautiful one. It's a kind of hidden grace in a walled garden somewhere. We have to find that out. Why is that? As I told you with a young lady with generalized dystonia, she had a normal development, normal milestones, and you can reveal the normal motor control sometimes, despite the fact that she had generalized dystonia. She had normal motor repertoire and motor development. And something that was pointed out in a recent paper is that a pattern of muscle groups and muscle synergy recruited to task are normal, despite the fact that dystonia is present, and sometimes in some of the movements, including dystonia. There is, and that's part of the normal movement variability, and that's helped for adaptation, like skiing when you move. But when there is too much noise, it just makes the system completely chaotic and unsteady. And sometimes we are surprised to see some of the patients, they have a glass of water and you think that they will not get it, and they do. They have a very good adjustment of motor strategy to the most ergonomic movement despite their dystonia. So they can reveal underneath their normal motor control. And in some movements, they can even activate the non-dystonic networks, and they can work backwards, for example, or do some movements. So to search for this hidden grace, and I think there is a grace in dystonia and a beauty in it, we will have to go through the walls of this closed garden. We are on the road again, and some of you someday will take me and us and all of us on their new roads. And for that, and thank you for your attention, I would like to pay a special credit to my team, and that's a great moment to have. And also to my mentor, Vidailhet, Stanley Fahn, of course, who was really very inspiring, Pierre Pollack, the late David Marsden, Philip Thompson, I did my master's degree with him, Buzz Gina, Mark Hallett, Tony Lang, and many of you, and I cannot put that all on the slide. and it's to my father. Thank you.